Good afternoon, everyone. I think let's take a moment for the participants to settle down. All right, so welcome to the ImmPort webinar series. My name is Sanchita Bhattacharya. I am the science program lead for ImmPort. On behalf of the ImmPort team, I extend a warm welcome to the participants and thank you for joining us. I will be moderating this session. Today, we have the privilege of hosting guest speaker, Dr. Sandra Andorf. Recently, Sandra published an impressive paper harnessing the learning early about peanut allergy LEAP trial data from public repositories, including ImmPort. We'll hear about the reuse of clinical trial data and novel insights from the secondary analysis. Before we begin, I would like to cover a few housekeeping items. There will be a Q&A after the presentation. Please feel free to post your questions under the Q&A window at any time during the session. The webinar will be recorded for future access. So Dr. Sandra Andorf is currently an assistant professor at Cincinnati Children's Hospital and the University of Cincinnati College of Medicine. Sandra completed her PhD in bioinformatics from the University of Potsdam, Germany. She has worked at Stanford University for over 8 years, first as a postdoctoral scholar and then as an instructor. During her postdoc with Dr. Atul Butte, she started to work on data reuse projects for ImmPort. After that, she worked as a director of computational biology at the Sean and Parker Center for Allergy and Asthma Research at Stanford, where she focused on better understanding the causes and treatments of food allergies. Sandra's research interests center around computational approaches in the intersection of clinical and immunological research. The title of today's presentation is Subgroups and Intervention Effects in Infants at Risk for Peanut Allergy, a reanalysis of publicly available data. With that, I'll turn it over to Sandra.
Thank you for the introduction, for inviting me. Let me share my screen. Okay. You see the full screen?
Yes.
Okay, perfect. So as I said, thanks for the introduction. Thanks for giving me the opportunity to talk about our project that we published recently. I will first give you an introduction about food allergy and then especially the LEAP trial, and then go into the secondary analysis of that we did on this LEAP trial. Food allergy, and this is a great infographic from FAIR. It affects about 33 million Americans have a food allergy. That for adults, it's about 1 in 10, and children 1 in 13, or like 11 and 8%. A lot of these participants, or not participants, whoops, like a lot people with food allergies actually have severe reactions, about 51% of adults and 42% of children. That goes down to about 3 million patients visiting the emergency room every year in the US because of a food allergy. In the US, 9 foods cause the majority of the food allergic reaction. And amongst those, peanut is one of the main ones, especially in childhood. About 2% of US children have a peanut allergy. I will talk a little bit about diagnosis and management of IgE-mediated food allergy, but mostly to actually introduce a few terminology to you. I can expect that everybody knows these. So one of the diagnosis approaches, in addition, it's always about clinical history that the doctor asks about, is skin prick test, veal diameter. So it's like when the doctor pricks the patient with, for example, peanut, and then sees what the flares around the prick, and that's a veal diameter. The larger it is, it's like the more the skin reacts to the allergen. Serum food-specific IgE levels. So IgE is like an IgE-mediated food allergy, the antibodies that mediate the reaction, and they can be measured like specific to a food. So for example, specific to peanut. Similarly, there's like IgE against individual allergens, which are called components. So somebody's not allergic to the whole peanut, they are allergic to certain proteins, peptides in the peanut, and they are called components if we measure the IgE against these components. If we think about management options, one of the long-standing and common ones is to avoid the food. If somebody allergic to peanut, they should avoid peanut. There's more like management options like oral immunotherapy now, or like Solea, which I don't go into, or like didn't add here. Oral immunotherapy is an approach where the patient eats the food, starts at very slow doses, like over several months, they're getting up dosed to a certain amount, for example, eating 300 milligrams of the protein, of peanut protein. However, this is not a cure. Most people have to continue to consume the food regularly to actually stay what we call desensitized, so that they can consume the small amount of the peanut. They cannot just stop. So all that said, there's some management options, but there's no cure. And not only because there's no cure, but in general, like there's always prevention is better than treating it later. So what about prevention of peanut allergy? Here's a document that's from a consensus document from several professional societies about the assessment of risk of food allergy development in infancy. The general population doesn't have a high risk. The risk gets higher with like family history of atopy, mild or moderate eczema, other food allergies, and the highest risk is given if an infant has severe eczema. And especially like the LEAP study based on this, and I will talk a lot more about this, and the NIAID addendum guidelines also said that severe eczema and or egg allergy are the greatest risk factors for developing a peanut allergy. Why is this? Like the leading idea of this, and this is actually a paper from Gideon Luck, who's also like the main author or like the senior investigator of the LEAP trial that I will talk about, is the dual allergen exposure hypothesis. It's currently accepted theory regarding why kids with eczema develop food allergy. So the idea is that like skin exposure to a food increases the odds of developing sensitization or food allergy, whereas like the oral exposure to a food decreases odds of developing a food allergy, so increases the odds of actually having tolerance. One question is, of course, the timing and balance between these exposures, and this is where LEAP was one of the landmark study, or like to show that early dietary introduction is important to develop prevent the development of peanut allergy. The LEAP trial, published in 2015, done in the UK, they enrolled 640 children between 4 and 11 months of age. They were considered at high risk for peanut allergy. So as I said, existing egg allergy and or severe eczema was the criteria here. They had a peanut skin prick test wheel diameter of less or equal to 4 millimeters. And that's important because the idea is that like everything that greater than 4 millimeters is considered likely already peanut allergic. So they wanted to enroll high risk infants, but not like the risk of them really actually already having a peanut allergy. They randomized them into two groups. A consumption group consumed a peanut containing snack starting between 4 and 11 months old when they were enrolled until 60 months old. And it's not only the early introduction, it's also the continued eating of the peanut snack. And an avoidance group that did not ingest the peanut containing food. The primary outcome was peanut allergy set out at 60 months of age. And they saw that there's a significant reduction in peanut allergy prevalence with early introduction. The avoidance groups, so those that did not consume peanut, had a 70.2 prevalence of allergy and a 3.2 prevalence of allergy in the consumption group. So it really this was, as I said, the landmark study that really showed that the early introduction of peanut has a positive and significant impact on reducing the probability of developing peanut allergy or having peanut allergy at 60 months of age. It followed a lot of different studies and different foods, and the consensus by now is mostly that for egg and peanut allergy, it's pretty accepted that early introduction really has a positive impact on preventing the development of egg or peanut allergy, or reducing the probability of developing peanut or egg allergy. This is from a systematic review and meta-analysis shown here. So why do we even there's still a lot of research going on in the field. And one of the reasons is maybe so accepted, and sorry for a lot of text on the slides, this really did lead to actually a lot of guidelines changing. And this is just two examples here. They're a little bit different between countries and professional societies, but they usually say something like introduce peanut-containing products to all infants, irrespective of their relative risk of developing peanut allergy starting around 6 months of life, though not before 4 months of life. The NIAID addendum a little bit different. They stratified more. They said something like infants with severe eczema or egg allergy should introduce by 4 to 6 months of age with testing priorly done. Infants with mild to moderate eczema should introduce around 6 months, and all other infants can introduce freely. So generally, this like peanut introduction has been shown to be effective, but there's still a problem with like acceptability of early peanut introduction remains amongst the caregivers. Like some caregivers are still very hesitant to introduce peanut. And one like evidence for this is a survey, which is a few years ago old by now, that only 31% of caregivers showed willingness to introduce peanut before or at 6 months of age, with 40% willing to do it after 11 months of age. And for example, also the E trial, which is another early introduction trial for several foods in a general population, but they had a below 50% adherence rate to the protocol of like the high consumption group. And that was partially due to feeding difficulties and symptoms. So there's still like a lot of research to be done in the area of like early introduction to prevent food allergies, even though there are a lot of evidence points, especially for peanut and egg, that this is really effective. That brought us to our study. So the secondary analysis of the LEAP trial data. What was our objective? The objective was to determine risk subgroups within infants at high risk for peanut allergy according to their predicted probability of developing peanut allergy if they avoid peanut. And we are not the first ones to do this. So this is only 2 examples of papers to define the window of opportunity in target populations to prevent peanut allergy, or like a recent 2022 early introduction of peanut reduces peanut allergy across risk groups. And there's more papers that really like look into like what are more risk groups for like that are at risk to develop peanut allergy. These papers usually use not only LEAP, but more cohorts, which we didn't have access to. What is maybe different in most of these papers to ours is that they often use or usually use pre-specified subgroups. Well, we actually looked in like using machine learning to find risk subgroups within these infants in the LEAP trial. And that's what, like, after we have found these risk subgroups, we estimated the intervention effect of early introduction of peanut for these risk subgroups. So this was, as Sanchita said previously, or like in the introduction, this was published in January of this year. And I definitely have to highlight the team that worked on this. Ishan is a biostatistics grad student here at Cincinnati Children's, who really did all the hands-on work on this. For this project, I co-mentored him with Bin Huang, who is a biostatistician, professor of biostatistics here at Children's. And of course, these trials never work without these trials. These studies should not be done without clinical input of somebody who really sees these kind of patients. And this was, in this case, Ashley Devonshire, who's a professor or like assistant professor here at Children's, an allergist who has really focused on like the bite clinic. This is like for children or infants with food allergies. So she was integral to this work. So the whole team, this work, if you want more details, you can read the paper. I cannot talk about everything. So where does the data come from? So LEAP is actually shared on 2 platforms. One is like through ImmPort under the ID SDYC660. And this is not only LEAP, but also LEAP-ON, which we didn't use, but they put them into one ID. Together, LEAP-ON is a follow-up of LEAP, like longitudinal follow-up, like afterwards. Or at the IT and TrialShare webpage. Both of these are NIH funded, so they are like there to share NIH trials, while ImmPort is like for any kind of trials. So it doesn't need to be NIH funded, any kind of trials or like data studies. IT and TrialShare is from the Immune Tolerance Network, so it's their own platform. Both you don't need to like pay for the data or anything like this or write a proposal. You can register and access the data. So when you register, you of course sign data use agreement, but you can access the data for research purpose, which is like great, and very grateful for them to make all these data available. So what we did, step 0, download the raw data from the LEAP trial from IT and TrialShare. And we just pick IT and TrialShare at this point. Actually, Ishan picked it without a lot of reason. We could have as well downloaded them from ImmPort. It's step 0, like maybe minimizes it. We could have really, or should have called it step 1, because everybody who uses somebody else's clinical trial data knows that there's a little bit of a learning curve to actually understand the data. There's like raw data, derived data. So one of the first things that we always do, which I actually don't have slides for, but like what I recommend always using, not only clinical trial data, also like mechanistic data, to actually reproduce a paper, not fully. And it's not about questioning if they did anything wrong. It's more like really for us to understand if we really know the data correctly. It's not the full paper. Usually, like I try to reproduce the flow diagram. It's like, who dropped out and what moved on in which phases. So can we find all these participants? And then reproducing table number 1, demographics table. Did we identify the correct participants in the correct arms? Like, this was a very clean data set, but it's not always that straightforward. So it's always good to like check for yourself if you actually understood the data correctly and can find the data in what you're doing, what you want to do. Otherwise, it might lead to something arbitrary. Step 1 was to predict risk subgroups in infants at high risk of peanut allergy. So for this, we used the infants from the avoidance arm, 314 participants. We used a set of input variables, which I will talk about what we did. We applied a random forest for feature selection, so to pick which variables are really predictive at baseline if they develop a peanut allergy at 60 or have a peanut allergy at 60 months of age. And then we built a decision tree out of these important variables. And I will give you a very brief introduction to random forest and decision trees, but this is a general workflow so that we get at the end to risk subgroups, which we define at each of these terminal nodes being one risk subgroup in the decision tree. The second step is then to actually estimate the intervention effect. For this, we classified the participant in the intervention arm into this model, like in which node did they end, and then use stabilized inverse probability weighting to estimate the intervention effect. As I said, a very not technical mathematical introduction to decision trees. Probably everybody saw a decision tree before. You have a set of input variables or inputs. And that is, for example, is it red? Yes, and go to the left side. Is it not red? Go to the right side. Is it underlined? Yes, go to the left side. Now go to the right side. There's a lot of nice features of these decision trees. One is they are very interpretable. Like, everybody think about this as a clinical model where it's like go to the left or the right. You can interpret it. And they can handle both numeric and categorical data, which is not always the case for all machine learning approaches. The big disadvantage is they are very prone to overfitting. One approach to mitigate this is actually to prune the tree, so reduce how deep you grow the tree. Of course, if you grow the tree endlessly deep, you will always overfit. So we did this in our second step, and I will introduce this later. But another approach is why not just grow several trees? And this brings us to the random forest. It's an ensemble of individual decision trees. Of course, not each tree is grown on the exact same data. They will not be exactly the same because there's some stochasticity in it, but they will be very similar. So we want to grow several trees to predict, in our case, peanut allergy at 60 months of age, but they're not all the same. And the low correlation between these trees is achieved during training by 2 steps. One is called bagging, so it's bootstrap aggregation. For each individual tree, there's a set of samples used that's generated by randomly picking samples with replacement. So the sample is not subsetting, the sample size stays the same. You just pick randomly out of the popular, a pool of all samples with replacement. So you might pick some samples 10 times. The second step is the feature randomness. So for each node where we split, only a random subset of the features in the sense are the variables, are considered. So that way we generate or we grow a lot of decision trees in our forest. They are having a low correlation with each other. And at the end, you actually, on the right side here, you count up each of these trees predicts, if you get a new case, there's 6 ones and 3 zeros, so the prediction would be 1. The advantage of this is they have a reduced risk of overfitting. They're easily determine variable importance. This is actually something that I see often. I mean, there's definitely research done or studies done where random forests are really used to develop the models. But I also see a lot of papers or research similar to ours where actually random forests are used as a feature selection step. We want to know which variables are the most important variables to predict peanut allergy status. And then those important variables we put into a decision tree to build something that we can interpret. Of course, the bigger disadvantage of random forests compared to single trees is they're not interpretable. There's not a simple rule that you can follow at the end. So that's a little bit of background. And let's now get into our actual first model, baseline model with limit of detection adjustment. I will not talk about all these. I put in the whole demographics table of the avoidance arm, so the infants that do not eat peanut in here. But the main things that I want to highlight is there were 314 infants in this arm, and only in quotes 54 of them developed an allergy, and 260 did not develop it or had no allergy at 60 months of age. So this is important to keep in mind. So this is typical for prevention trials. This is called the dilution effect. Even without the intervention, it's only 17% that are actually peanut allergic. I mean, we saw like LEAP showed that they reduce this number significantly, but it's not a trial where like the basically control arm had a close to 100% of cases or something like that. Just to keep it in mind, so this is the numbers we work with. We have 54 allergic, 260 non-allergic participants at 60 months of age. So which are the variables that we put into the random forest? We use age, sex, and race as demographic variables. We use peanut-specific IgE, peanut-specific IgG4. IgG4 are a different class of antibodies. They are considered more protective as opposed to the IgE. IgE to RH1, 2, 3, 8, and 9. And when these RH are the components. So these are the allergens for peanut. So they just code like that and have like the numbers. So these were measured for this trial. Clinical variables, we use severe eczema status, allergy status, and skin prick test stratum as input. Previously, I mentioned like the limit of detection adjustment that we did for our base model. And this comes from that because in clinical practice, laboratories often use lower limit of detection for specific IgE measurements of peanut and the peanut components of 0.09. However, for clinical trials and a lot of other research studies that analyze the data for the resolution at the lower limit of detection is often higher in research or clinical trials than in clinical practice. So to create a model that we think like would be the most useful in clinical practice, we basically impose the limit of detection of 0.09 to on all specific IgE values and filled in everything that's below this with half of the lower limit of detection. So we use 0.045 for these specific IgE values. The random forest that we applied found two important variables for predicting baseline variables, so meaning they're 4 to 11 months old infants to predict allergy status at 60 months of age, RH2 specific IgE and peanut specific IgE. This red line shows the threshold of the permutation importance that we considered as the threshold to find important variables. This is based on the absolute of the most negative value here, because permutation importance measures if you permute the variable, so you mix up the values of the variable, like how much more errors do you get actually in the prediction? So if you mix up, like if you basically you permute the RH2, the model gets much worse. So they have their permutation importance is high. A negative permutation importance actually means that like if you mix up the variable, you get better in your model prediction, which can be like even if the model has like no impact at all. It should just not be considered. So we use the absolute of this value of kind of where's the noise. Everything outside of this we can consider as an important variable. To put something objective on here, how we pick our variables in the random forest as our important variables. Next, we built a card because we wanted to have an interpretable model and like risk subgroups out of this. And we did this on case-weighted data because of the class imbalance. As I said, only 17% of the participants were determined allergic at 60 months of age. So each class was weighted by the inverse of the proportion of that class to really have a class balanced data to grow in our tree. And then to determine where we pruned our tree, we first did grow a full tree, like as deep as we can grow it, and then use tenfold cross-validation to find like what is the best complexity parameter to split, like how deep should we grow the tree. You can see here in purple on the y-axis is a balanced accuracy. The training set, the further to the right we get, the more splits do we have. Like the training, of course, is a much better accuracy the deeper we grow our tree. But the test set gets worse because at this point we start to overfit. So we determine the complexity parameter corresponding to 2 splits as the best tree to have a best balanced accuracy weighted against like test and training set. So this is the tree that we received out of this. The first split happens at peanut-specific IgE. We didn't write it here, but SIgE stands for peanut-specific IgE at baseline with a limit of detection adjustment greater or equal 0.22. Then the infants are categorized into this node here, and on the lower row we have the weighted numbers. So out of the weighted data, we would have 206 that are allergic and 62 that are not allergic. Unweighted, there's actually more allergic, like 51 that are allergic, 36 that are non-allergic. If you would only look at these, we would classify them all as non-allergic. I mean, even if like for a model, if we say like everybody's non-allergic, we would still have an accuracy of 80%, just because there was not that many or greater than 80% that were actually allergic. So here we call this like every infant classified into this node as like likely allergic with a probability of 41%. If you have, if the infant has a limit of the like phenotype-specific IgE at baseline less than 0.22, but greater the RH2 as IgE of then 0.1 or greater or equal, they're classified into this node. It's a very small node, which probably biologically makes sense. If they have low IgE, they're probably not having a high IgE, like low IgE to peanut. They're probably not having a high IgE to RH2, but there's still a few infants in here. There would be a 50% probability of having a peanut allergy, but it's overall not, I mean, it's a small node, so we didn't put a lot of weight onto this. If they have small, like low IgE, and then usually gets along with low RH2, and this data that we looked at, there's only a 6.8% probability of being peanut allergic at 60 months of age. So we saw here like that while all of them have still a high probability, or like higher than the average population, to have a peanut allergy, there's definitely a graded probability, which also other studies found. There's like still within subgroups still a graded probability of developing peanut. If keep in mind, this is an infant that did not eat peanuts, so they did not receive the intervention. Because peanut-specific IgE was the main variable, we were curious how this variable changes over time. Keep in mind, the model did not see these data. The model only saw the baseline data. And this is like on the x-axis are the baseline, 12 months, 30 months, and 60 months with it. Also keep in mind that this is their age, so 12 months is not 12 months past baseline, it's 12 months old. Y-axis is the peanut-specific IgE, they're on the log scale. On the top left are 206 infants. The gray line is per infant, the blue line is average of the true negative ones. So these were infants that had a low peanut-specific IgE at baseline, and the kind of, on average, the average line stayed pretty low. The bottom right is the true positive ones. So they were allergic at 60 months of age, and the model predicted them as allergic. You can see that the baseline peanut-specific IgE is, of course, higher. I mean, like it's just where the split was for the IgE. And they also seemed on average to increase a little bit until 60 months of age. In contrast to this, if you're on the top right, the false positive ones, so they are like non-allergic at 60 months of age, but they were predicted that they would be allergic. They start similarly high at baseline. Of course, I mean, that's just like the variable, the peanut-specific IgE they were classified by. But then they reduced on average. And also the gray lines, by the kind of go a little bit up and down, but they really show the upward trend, they do go down. So the model didn't see this data, and obviously like the model didn't see any other variable that would catch that they will go down. But this is like, you know, we probably misclassified them because yeah, their IgE reduced over time. Similarly, the false negative, so the allergic group is a non-allergic prediction. And down here, they had like really low baseline values, but they really increased up to 60 months of age. Here, at this point is where they determined to be allergic. So again, the model only saw the baseline variables, but like, yeah, this kind of like was a little bit for us to really understand maybe why did we misclassify them, or our model did misclassify them. So now we had our risk subgroups. Again, each like terminal node, we considered one risk subgroups. We wanted to determine the intervention effect for each of these risk subgroups. For that, we used infants in the intervention arm, and only those infants that actually received the intervention. There were, I think, 7 infants that actually were deemed allergic. So like they were tested to be allergic at baseline already, so they didn't receive the intervention. So we excluded them from this trial, or from our study. So we had only 300, out of the 307, only 6 were allergic at the end of the study. So the first step that we did, we actually put these infants into the random, like into the card model, and found that like 78 were classified into the last node, 3 into the middle node, and 226 to the left node, like to the risk subgroup. And in this risk subgroup that had 41% probability of peanut allergy, 4 out of the 78 were actually peanut allergic at 60 months old. We cannot directly estimate the intervention effect out of this, because if you run a clinical trial and a clinical trial design, the participants are considered exchangeable because they are randomized to the receiving the intervention or not receiving the intervention. But now that we look into each risk subgroup, so each of these nodes, we basically broke the assumption that they are like really balanced with each other. They might be unbalanced by now. So what we did first, we needed to ensure that these are like really balanced between the intervention arm and the avoidance arm. And we did this by applying stabilized inverse probability weighting before modeling the intervention effect. On the right side here, there's two plots. On the x-axis is a standardized mean difference. The y-axis are all the covariates. Terminal node 1 is on the left side, 3 on the right side. We didn't do it for the middle node just because the number of participants were too low. So we didn't weight them against each other. You can see in red, this is a standardized mean difference before the stabilized inverse probability weighting was applied. And you could see there's some imbalance between the infants that were categorized into that risk subgroup out of the avoidance arm, out of the intervention arm. But after we applied the weighting, they were all below 0.2, which we used as a threshold to consider that they were balanced. Doing this, we could estimate the proportion of allergic participants if both arms, like infants in both arms, receive no intervention as well as receive the intervention. Starting on the right side again with this node, like if all participants from both arms receive no intervention, they had a probability of 44% to be peanut allergic at 60 months of age. If both, like it's estimated if all infants in this, they were classified in this risk group would have received the intervention, they were estimated to be 3.88% likely to be peanut allergic at 60 months of age. I mean, the middle is like really small. It's like 50% if they receive the no intervention, 0% if they receive the intervention. But the confidence interval, just because of the small sample size, is between 0 and 69%. It's just like, this is just given because of the small sample size. As I said before, we didn't interpret this node a lot. This like last, or like the last, but the first in the order, it's a risk subgroup that's predicted as not allergic, had a 70.3% probability of peanut allergic if they did not eat peanut starting early until 60 months of age, and less than 1% if they received the intervention. So we calculate the intervention effect out of this. And interestingly, there's like the relative intervention effect is similar in these risk subgroups, but the absolute intervention effect, and this like risk subgroups was like greater than 0.22, peanut specific IG had an intervention effect of 40%, but the absolute intervention effect in this risk group is 6% or 6.5%. And they were all deemed significant, which is like also the other studies found there's like a graded intervention effect, but it's still all effective. So the peanut introduction, like this is nothing like this. Peanut introduction shouldn't happen here. Like peanut should always be introduced. This is just like there's like a larger absolute peanut introduction intervention effect in this risk subgroup than in this risk subgroup. After this, we did several sensitivity analysis, but one of them is like, what if you actually don't do the limit of detection adjustment? I mean, we put it on there for like making it more clinically like useful for the clinical practice, but of course, like how do the models look like if we don't do this? The random forest picked up the same two variables important, RH2 is peanut specific or peanut specific IG. The tree is almost exactly the same, with the difference being that this split used to be at 0.1 and now it's at 0.024 for the RH2 specific IgE. So value that is actually below the limit of detection that we imposed on the data. And interestingly with this, looking at the intervention effect, I mean, we have more like now in the middle node because there's more infants that have a peanut specific IgE less than 0.22, but still like a detectable RH2 greater than 0.24, which is like barely only like just almost considered like detectable, but it's non-detectable. Which has like the right now it still has like a 40% absolute risk reduction intervention effect. The middle node at 20%. The most left node is a 2% reduction of like probability of peanut allergy by the intervention. Interestingly, it was not significant because the confidence interval included 0. I'm not a clinician, so I could not give any recommendation anyway, but even if I would be like, no, we do not want this to be understood that there's like, you should not introduce peanut to those. There's enough studies that show that introducing peanut is safe, unless they're already peanut allergic, of course. So this is, I don't want this to get understood this way. This is really like, maybe there's a subset where it's like really the probability is low. Even though the actual relative reduction here was still 60%. So it's still reducing from 3.5 to 1.3. But it's like, it just not happened to be not significant because the probability was pretty low to begin with. Here again, we looked at this, and mostly I show it again for you to just actually introduce the next topic of the talk. Again, you see the true negative ones. They're like pretty consistently low peanut-specific IgE over time. The true positive ones increase. Interestingly, we see the false negative ones, so those that are allergic but were predicted as non-allergic, they actually go up constantly, while the false positive ones stay constant. So one thought that we had, or one question, like these go up and these go up. Is it maybe more the change in IgE that predicts than like the actual absolute value? Of course, they stay flat and they stay flat. So is it like really the change? So what we did is we actually built a model using baseline and 12 months data, which is 100% acknowledging that this is not really clinically relevant, because if a clinician sees these infants at baseline, they probably should recommend introduction, not wait until they see them at 12 months. But it's just like really for us to understand, maybe is it like the change in IgE that's really more associated with developing allergy than the actual absolute value. So we use the same variables that we used before at baseline and 12 months. But additionally, we used the delta in months between baseline and visit, because visualized here on top. So we have the baseline ages in months. And they were enrolled between 4 and 11 months of age, but the next time point was at 12 months. So some of them had a much shorter time between the enrollment or like starting the trial to actually the first time point, while others. So we included also variables about delta in months, delta in peanut-specific IgE between baseline and 12 months, delta in RH2 IgE, as well as a slope to adjust for that these infants had much longer time, or like the IgE had much longer time to change than up here. If we now did the random forest with this, like more variables were picked up as like being important variables for the prediction of peanut allergy at 60 months of age, including the difference in RH2 and the slope in RH2. Interestingly, when we built the tree out of this, none of these like changing of RH2 over time were included. Most variables were actually just from 12 months. So it seems like, okay, the closer you are to like what you want to predict, it's just really more important than really like what our hypothesis was, like maybe it's more the change that is important. But like now it turns out that mostly the 12 months data just like is better predictive of allergy at 60 months and baseline, or the change from baseline is. This is also reflected if you actually look at the AUCs of our data. So we see here that the best models were where we use baseline and 12 months data, followed by 12 months data alone, which I didn't show you actually the model. And the baseline data model with like limit of detection still had an AUC of 0.76. To actually summarize this work for you, so we utilized publicly available data of infants at high risk for peanut allergy from the LEAP trial to determine risk subgroups and estimate the intervention effect of early peanut introduction for each of these risk groups. We found that infants with a baseline peanut-specific IgE greater or equal to 0.22 benefited the most from the early introduction of peanut, with an absolute reduction of 40% for the risk of peanut allergy at 60 months of age. This is in line, as I mentioned before, with like prior studies that found like that there's a graded but significant benefits across different risk subgroups. The intersection, there were significant across all risk groups if we did the real-world limit of detection. And we believe that these results are relevant for further risk assessment and clinical decision-making, and can actually maybe be used for educating caregivers about the benefits of early introduction, and maybe counter possible hesitancy of introducing peanut early. Every study has limits and considerations, and especially like we reuse data that were not made for what we specifically wanted to do. So these models were built on and applied only to infants as eligible for the LEAP trial. So exactly how they were randomized or like enrolled in the LEAP trial with the inclusion-exclusion criteria, this is the only population we can right now say that they apply to, because we didn't have another population to test this on, or like another cohort to test this on. So it cannot be applied to any general population or other infants. So that, and the LEAP trial, to remind you, included infants at high risk for developing peanut allergy with skin prick test less or equal 4 millimeters to peanut. There was a limited number of infants with peanut allergy at 60 months of age. So some of the confidence intervals were just really large. And this did lead to the dilution effect that I mentioned before, that the intervention effects are just small, because even without intervention, there was not that many infants, luckily, that developed a peanut allergy. And we can only predict peanut allergy at 60 months of age. So this could not predict if an infant developed a peanut allergy and outgrew it again by 60 months, or if they develop it later. So because this is a time point that allergy was assessed at, so we can only assess 60 months, or like only predict 60 months of age if they have a peanut allergy. I'm happy for questions, and I need to definitely acknowledge Ben, Ishan, and Ashley, as I mentioned before, but also Ting Ting and Justin help a lot with these kind of research. And overall, I didn't speak about it, but like a lot of the research that my team and I do is about utilizing raw clinical trial data. Because I feel like there's so much potential in reutilizing these data. I mean, they're not perfect because they were not generated for the question that you want to ask. But with more and more data, like raw clinical trial data being shared, there's so many questions we can ask. And if it's just to generate hypotheses, or like across clinical trials. And ImmPort and IT and TrialShare are great research for this, and to share their data. And like, of course, as I wrote also here, thank you to everybody who the investigators of these trials that make these data available. I know that this is also really a lot of work to make these data available, but I think there's so much potential to reuse these data. And it needs in clinical trial data a little bit time to pick up to be on the same level as it is like for molecular mechanistic data, which are more frequently reused. But I think we can all work in this direction. ImmPort is a big impact on moving this forward. So, and I'm happy to answer any questions.
Wow, that's a great presentation. I will remind the participants, please feel free, if you have any questions, post under the chat, Q&A tab. Okay, I see one, so let me read out. So basically, the question is, did you look at the baseline SPT value or just the SPT stratum?
We used the stratum. We thought a while about it, but we did it because in the original trial, they separated it by stratum, and we wanted to follow that. But I mean, it's a valid question. We probably should have also put a sensitivity analysis where we really put this, the skin prick test itself as a value in. At the 12 months point, we put it in, but yeah, not at baseline now, unfortunately not.
While others are posting the questions, definitely I have a lot of, it is a great talk, and I have some questions for you. So, well, from the plots, I could see that you don't have much of the gender and race effect, right? Or did you look at those as well?
No, we did. Let's say they were included as variable, but they were not picked up as like the tree. And then we didn't look, or like in the random forest. So we didn't look further into this. I actually don't know right now if you just look at the demographics tables, if they were different. Yeah, I don't know. Let's say we did not look specifically into it. Yeah, I mean, race was actually significantly different here, but yeah, we did not look into it. Like we gave it as a variable, as an option for the random forest to pick it, but it didn't pick it. I think it was close, though. I think it was like, I mean, it didn't make the cutoff, but it was definitely up here. Yeah.
Okay. Okay, there are other questions coming up. Was eczema severity a predictor?
No, it was pretty much not a predictor. I mean, yeah, it was, again, it was like binary. It was severe or not. Like I'm not 100% sure if Leap shared it, but maybe they did, but we didn't use like if there's like scorot or something like that. So we didn't use any continuous variable here either. So it was just like, did they have severe eczema? Yes, no. Of course, the inclusion was either egg allergy and or eczema, severe eczema. So, but we didn't use any like continuous variables for those.
Okay, I'll read the next question. For the random forest model generation, where you chose random sets of samples different times, did you do this for training and test set data or just one of the sets?
That one we did only do for one set. We didn't do training and test set. I'm actually Oh, I'm not 100% sure. Let's say 80%. I would need to ask Ishan, honestly. Yeah, I take it back. I'm actually honestly not 100% sure. Yeah, sorry. Whoever asked the question, I can get back to you and like need to look it up. I should know that. I apologize.
Okay, so
we
maybe
definitely looked at it several times because random forest is still random. So we looked at it that we didn't like pick up an outlier, but like that's not the same as like what you asked. So I apologize. I should know that.
So since we have some time left, I have one more question for you. Maybe this is a very naive question I'm asking. Why did they choose 60 months? Or are you following them beyond 60 months?
60 months was the time from the clinical trial. I mean, we didn't, they followed them like there was a sleep on, and we thought about if we like should maybe do a second analysis and see how they follow up. But it's just like, that was set by the trial. That boils down to we didn't generate the data, we used data, and they used 60 months as like the endpoint to assess. So we just had to use the same.
Okay, thank you. I see another, I think it's a question or just I'm reading it loud. Most infants were chosen on the basis of eczema. So not surprising, it is not a predictor, probably.
Okay, yeah, thanks for that's good info. Yeah. Yeah.
All right, any other questions for Sandra? Okay. Thank you, Sandra.
Thanks everybody for your time.
That was a great presentation, and I will take a few minutes for some announcements.
Try to stop sharing.
All right, I can share. So first of all, thanks for your participation. I just wanted to show you some of these ways that you could go to ImmPort website, and if you didn't get chance or your colleagues didn't get chance to attend the webinar, there are ImmPort webinars archived or posted on the ImmPort website. So if you go, either the link is provided at the bottom, or you can just scan through the QR code, which will take you to the webinar archive webpage. And then ImmPort hosts office hours as well. So ImmPort holds open office hours session on the first Thursday of each month from 2 to 3 p.m. Eastern. So it's a great opportunity, very interactive sessions. If you have any questions about the data or either data submissions or how to retrieve data from ImmPort, I think it's a great opportunity to attend the office hours. And people from all the levels, it's not that you need to be a bioinformatician or a bench scientist. Anyone who is interested in data can come and ask the questions. Also, I will encourage the users or the participants that if you want to stay connected with ImmPort, we have newsletters, we have events page, and the links are provided here on the right-hand side with QR codes. So please go ahead, and if you're interested, just fill out the registration form. And we have newsletters every month. So it's a monthly newsletter where we share the new data sets on ImmPort, or any publications, any events going on related to ImmPort, or data reuse, data repurposing. So that kind of helps to stay connected. Also, I would like to mention about big data workshop that ImmPort hosts every year at Focus. And so if you are interested, this June, on June 18th, we are conducting a workshop, big data, and with focusing on AI tools, how you could use AI in either downloading the data or probably how to curate and put together metadata for downstream analysis. So if you're interested, please feel free to register at this workshop. And then there's a AI and immunology symposium sponsored by NIAID. So this kind of is another opportunity if you're interested to explore the opportunities and challenges in the field of AI and immunology. And on the right, there is a RFI on NIAID Immunology Knowledge Management. So with the RFI link being given here on the screen. So if you're interested, take a look. And with that, I would say that we had a great session today. And thanks for your participation, and look forward to seeing you in our next webinar. Thank you.
Sanjita, we did have one question that just came up recently in the chat about how to access data.
Okay, sorry, I apologize. I can't see the chat window presenting. Okay, so
For me or one of you guys?
okay, so the question is, could you just walk us through how to access the data? Any data is fine, or just a quick walkthrough will be fine. Yeah, can you just walk us through how to access the data?
Unmuting. That is actually, do you want me to go to the webpage? I'm not sure if I can, because I would share data. You have to make an account. So I think ImmPort and IT and TrialShare are very similar in the sense. Actually, ImmPort, you can look at the data, you can see the data without having an account. Just if you want to download the data, you need to make an account. IT and TrialShare, I think you have to register, but it's free. And then you have to log in, like you have to do this before seeing the data. And as I said, you kind of sign like data use agreement when you do this, but I don't remember the details, read it through. But it's definitely, you cannot make money out of this, but you can access these data. Like by downloading them. And then if you download it, like in IT and TrialShare, there's like, you see the different studies, and you can go to the studies, and it's very nicely presented. You also see the study protocols, and like ImmPort is the same, the case report form, so you can really understand the data. In IT and TrialShare and ImmPort both, they link it to the paper, so you can read the papers. Also recommend always reading the papers or reproduce them, as I said, to understand if you know your data, if you understand the data correctly. But it's actually, yeah, you log in. There's actually something like, it's not part of this, also called Vivly, which is different. Vivly is pharmaceutical sponsored trials. There you have to write actually a proposal. You don't have to pay for the data per se. You have to actually pay for computing power, but like you have to write a proposal to access the data. So the nice thing with ImmPort and IT and TrialShare and a lot of the other NIH funded things, you don't have to write a proposal. You can basically just access the data as long as you agree to the terms to access these data. And then, yeah, they both have nice interfaces to access the data. Did that answer your question?
I did respond to the person who asked the question. I'm not sure who it was. It says it was an anonymous attendee, but I pasted the link to that particular study, study 660, response to your question.
Oh, but if that was a question, yeah, sorry, no, I thought it was more general, yeah.
Yeah, not sure where the question was coming from, which angle, but I think we covered both angles either way.
Yeah.
Thanks, Sandra.
Next question is for me that, yes, this session is recorded and we will share it with the registrants. Okay, so I think then we close the meeting, and we will see you soon in the next webinar. Thank you very much again, everyone. Bye.
Thanks.